Good morning. Good morning. This is the first participatory part of the morning. So everybody, good morning. All right. So it is 10:01. When have you been at a conference that actually starts right on time? A very uncommon event. First, I want to thank all of you for being here today to talk about this really important topic. I should introduce myself. I'm Dr. Patrick Conway. I'm the Deputy Administrator for Innovation and Quality at CMS and Director of the CMS Innovation Center. This really exciting day for me personally and for all the staff at CMS. I do want to thank all the staff that planned the event today. A ton of thinking went into this and really important topic, and we look forward to partnering with you throughout the day. I have 7 days left at CMS, which is bittersweet in many ways, and will be going on to be CEO of Blue Cross Blue Shield of North Carolina, trying to build a model Blue health plan. I was just kidding in the back. Not only do we want to deliver mental health parity, my personal goal would be mental health and behavioral health parity plus. So how do you actually have even better care in the mental and behavioral health arena than in other arenas in healthcare? How do you really try to be a model health plan? And I know CMS, which is going to be our focus today, also this is a major focus area. The CMS Innovation Center is responsible for testing new payment and service delivery models. We have done some work in mental and behavioral health. We're here today because we think we have not done enough work, and we want to hear from you, given that this is a priority area moving forward for the administration, for CMS, for the CMS Innovation Center, and we all think we can do better in the mental and behavioral health arena. We want to hear from you. How can we do better? I was talking backstage. There's a number of priorities we have going forward where I'm pretty sure what the payment models are and what we need to do. This is an area where I have some hypotheses, but our team really wants to hear from you. What are the biggest impact things we could do? And I challenge us all to think outside the box. Backstage somebody said, what if we deployed as in a national emergency fashion and had funding for the Public Health Service Corps to address some of these issues directly? What if we had an all hands on deck, every single lever in a state and locality to see what's possible in a state and a locality to drive change? So I'll encourage us all to really think outside the box. On a personal level, like many of you, this issue has touched my life. I think we'll hear from experts on substance use disorders, mental health disorders in the presence of co-occurring conditions, Alzheimer's disease, behavioral health workforce challenges. Feedback from the summit will be used to shape future work for the CMS Innovation Center. And we can never obviously promise exactly what model we can do, et cetera, because there's a whole government process as we launch models, which we know well, and we will try not to bore with you with too much today. But we do promise to listen, to learn, and to try to directly apply the work today. Today's summit will be moderated by Chris Ritter, Director of the Patient Care Models Group at the CMS Innovation Center. I now have the pleasure to introduce the Honorable Mr. Patrick Kennedy, who will deliver the open remarks. He'll be followed by Dr. Terry Klein. Mr. Kennedy spent 16 years in the U.S. House of Representatives, serving Rhode Island's 1st Congressional District, fighting to end discrimination against mental illness, addiction, and other brain diseases. He is best known as the leading sponsor of the groundbreaking Mental Health Parity and Addiction Equity Act of 2018. Since leaving Congress in 2011, Mr. Kennedy has kept his promise to do everything in his power to fully enforce the parity law and to push for greater global investment in brain research, which he has called the next great frontier in medicine. Toward this end, Mr. Kennedy founded 2 innovative nonprofit organizations that are changing the lives of people with mental illness, addiction, and other brain diseases in the U.S. and around the world. He's now serving on the White House Commission on Combating Drug Addiction and Opioid Crisis. On a personal level, I had the pleasure of attending a Kennedy Forum event in Hyannisport, and 2 important things from that event. Most importantly, it actually led to a lot of CMS's work to implement the collaborative care model and Dr. Matt Press is here who helped with that, and many of the CMS staff, but to implement nationally the collaborative care model, including outcomes measurement. So I want to thank Mr. Kennedy and the Kennedy Forum for that. Secondly, my wife and 4 kids got to play in the theater in the basement, and he watched nicely, I don't know if he remembers this, and really enjoyed the event. And my wife said afterwards, and I've brought her to the Oval Office, I've done all sorts of things with my wife, she literally said, I don't think I've ever told you this, that because her parents' house was across the water from them, that this was the best event she had ever had that I had taken her to. So I want to thank you for that as well. Appreciate it.
Thank you, Patrick. Thank you, Patrick. And thank you, Dr. Conway, for your incredible service to our country. You've held such an important place of responsibility, overseeing the largest payer of health care in this country. And you've been willing and interested in trying to make sure that finally mental health and addiction is properly paid for and included in all CMS policy, including this conference here. Even as you're hitting the exits, Patrick Conway, you are leaving your mark on this fantastic organization by helping usher it into a new direction, one that will finally treat brain illness as the illness that it is and not as something else, something other, only to be relegated to the margins of our healthcare system because our payment system relegates it to the margins. So I want to say that there was a little manipulation in getting you to come and help endorse the collaborative care codes that we are so excited that CMS put forward. And that was knowing of your ancestry and just looking at you. I knew that if I invited you to sit in the chair that President John F. Kennedy sat in as he hosted cabinet meetings while President of the United States, that somehow that might be a compelling reason for the chief medical officer of CMS to come to Cape Cod and listen to our arguing our case for collaborative care. And I was happy to babysit your children. I was happy to babysit your children because I knew you were in the room with all of the biggest insurance companies. And all of them were wondering what was going to come out of that meeting. And I'll never forget everybody going to lunch and Dr. Conway pulling me aside and saying, Congressman, what do you want me to say when they all come back? And I said, wouldn't it be nice if after having heard this explanation from Jürgen Unitzer from University of Washington about the power of the impact model and collaborative care, 80 randomized controlled trials, that CMS was going to begin to think of all the different ways that they could reimburse for collaborative care. He said, I'm happy to do that. So, of course, he goes in there. We got all of the big payers come back and sit down with their sandwiches and said, so we got to talk about this morning's session. Dr. Conway, what do you think? Well, Congressman, I think it would be an important thing. In fact, I've already been emailing my staff back at CMS that we ought to be really reimbursing for these collaborative care codes. All of a sudden, Sam Nustrom dropped his sandwich and went right on his iPad and started sending messages out to Indianapolis, where Anthem is headquartered. And the same happened with all of the Aetna and Cigna and Humana, all of the insurance folks, which tells you something. And that's the reason we're all here today. That CMS has a powerful, powerful voice in how insurance overall is organized. So as CMS goes, so doesn't the rest of the insurance community, because they all take a page from what CMS reimburses. And that is why today's conference is so important. Let me just outline a couple of things and explain, my thinking behind them, because clearly I've relied on many of you in this room in order to come up with the recommendations that you can find at the KennedyForum.org online later today, where you can also find our members' guide for members of Congress, Navigating the New Frontier of Mental Health and Addiction. When I was in Congress, I found it shocking that if you cared about mental health and addiction, there wasn't a place to go where you could get the A to Z of issues that could help us tackle, and that there wasn't a guide that would show that no matter what committee in Congress you were on, you could do something to help address the mental health and addiction crisis in this country. In other words, it didn't have to be the Subcommittee on Energy and Commerce that was the only committee that took up issues of mental health and addiction. In fact, it was probably going to be the housing and HUD budget that would have as much, if not more, than any other agency to do with mental health, but nobody knew it yet. Or it may be the education budget because of the importance of doing better screening and identification early on, given the onset of these illnesses being illnesses of the young. But nobody knew that education department had anything to do. Or it could be the Department of Labor and the fact that DOL oversees all ERISA plans. But of course, most members of Congress would know that all of the regulatory authority overseeing all of the big payers is in the Department of Labor in terms of the regulations. My point is, and I know this is patently obvious to all of you because you often work within this beltway, understand the ways that it works, but frankly, there is an illiteracy out there in terms of what it is that members of Congress can do to tackle this crisis besides just taking a one-off approach that is often the only approach that we take when coming up with a complex issue like the opioid crisis or with the complex issue of how we're going to adequately deal with the suicide crisis in this country. So we need to have a comprehensive approach. I couldn't help but think about today's conference when I heard how FEMA was beginning to orchestrate a response to Hurricane Harvey and how they were even beginning to forward deploy their resources to address the impending disaster of Hurricane Irma. And they all said that the benefit of FEMA is that it was finally able to do a comprehensive approach to addressing a national crisis by including all federal agencies in the answer to that challenge. This FEMA was created as an act of Congress back in the 70s because the governor said we couldn't do a one-off approach anymore. We needed housing, job training, health care, transportation, and on, all to be part of the response to any natural disaster like what we've seen in Harvey and what we're beginning to see with Irma. That, my friends, is the template to deal with this tragic crisis of opiate overdose and suicide in our country. It must be a FEMA-like response. In other words, in order to tackle this challenge, we need to take a full picture of all the attributes that will support a community and all the liabilities that bring a community down, irrespective of the fact that those are healthcare issues or whether they're human services issues. And I think that the takeaway from today's conference will be how much can we incentivize through CMS funding the kind of wraparound approach to dealing with real-world challenges in a real-world way, and not in a one-off way that is often the way we're relegated to respond to these crises, because that is the only way we get paid. So the innovative models that you're going to be talking about today, which I talk about in my testimony, are all about how to deal with maximizing the different aspects of reimbursement paired with state resources, paired with private payer resources in order for us to try to put together a population health solution, especially at a time where we're under assault in terms of the undoing of insurance through the attack of the ACA. And let me just be one of those people to say quite clearly, there is no way of attacking the opioid crisis or the suicide crisis unless people are insured. I know this should be obvious, but let me just state it again. There is no way we're going to be serious about attacking this opioid crisis if we don't have people insured, which means we can't provide the kind of support and care for them that they need over a time that revolves around the chronicity of their care and provides a continuity of care and a continuum of care that's only possible if we're paying in an insured environment. If we go to block grants, we are not going to be able to sustain any of the innovative changes that we're trying to leverage through the payment reform mechanisms that CMMI is going to be talking about with all of your help today. But let me just finally just make a few concluding thoughts before we have question and answers with Dr. Terry Klein, the commissioner out in Oklahoma. And that is, any payment reform cannot lock in the same discriminatory reimbursement practices that we have historically seen by CMS. Let me just state it perfectly clear. I have traveled this country over the last 2 decades. I have spoken at every part of this country. I have met with every single stakeholder in this country, and CMS does not pay for, does not reimburse for mental health and addiction in the same way that it reimburses for medical and surgical care. I have on my team at the Kennedy Forum one of the lead litigators on parity compliance. In fact, this litigator settled some of the biggest insurance claims in this country in terms of fail first, in terms of other denials of care by some of the biggest insurers in this country. And if he were to put together a lawsuit taking the facts of CMS and the reimbursement levels of the behavioral health providers when compared with medical and surgical, he would have CMS in a consent decree because of the historic discrimination that continues to persist in CMS reimbursement practices. When we're thinking about new bundled models of care, we have to first fix the poor, shoddy, tragic reimbursement rates in the mental health and addiction space, first and foremost, because otherwise we're going to lock in the historic double standard that we've already seen in CMS reimbursement in terms of mental health and addiction care. 2, when we come to putting together these new bundle payment models, we have to ensure that those who are providing that care adhere to real outcomes, not process outcomes. Not process outcomes. We want to see outcomes-based metrics. We want to see severity scores improve. That needs to be the metrics. And understand that many of these providers themselves are guilty of a historic discriminatory mindset. So I'm not laying blame just on CMS. I'm here to say there is equal culpability across all of those in this country when it comes to not treating mental health and addiction in the way that it ought to be treated. The only way we're going to get past all of this is through the kinds of attentions that you're going to see brought to issues that are raised today. So I thank you all for being here, and I appreciate the opportunity to participate, and thank you so much.
Thank you, Congressman Kennedy. Certainly raised a lot of important issues for us to consider, and love the passion.